Hello dear students, I welcome you to yet another session of Studental. Myself Dr. Gagandeep Lamba, and I am a pediatric dentist by profession. Today we will be starting with the topic Management of Medically Compromised Children. The student should understand the various special healthcare need patients and its significance while managing in dental operatory. We will be dealing this under following headings: heart diseases, that is congenital heart diseases, infective endocarditis, respiratory system asthma, diabetes mellitus, and hematological disorders which includes leukemia, clotting factor deficiency, that is hemophilia, platelet disorders, and anemia. Now, what is special healthcare needs? According to AAPD, individuals with special healthcare needs are those who have a physical, developmental, mental, sensory, behavioral, cognitive, emotional impairment or limited condition that requires medical management, healthcare intervention and use of specialized services or programs. Now, these special healthcare need children can be divided into physically handicapped child and a medically compromised child. So, physically handicapped child is the one who has got some physical disability, while a medically compromised child is the one who's got a medical conditions and we need to alter the drug dosages or the dental treatment for such children. A handicapped child, according to WHO, is the one who over an appreciable period is prevented by physical or mental condition from full participation in normal activities of their age group, including those of social, recreational, educational and vocational nature. These can be classified according to disability, Novak's classification and dentally handicapped. So you generally get a SAQ on Novak's classification. Now let's see all these classifications. According to disability, a physically handicapped is one who's got hemiplegia or quadriplegia. Hemi is one part of the body, one half, and quadri is all the four limbs which are paraplegic. Mentally handicapped, example is Down syndrome. Sensory handicapped, that is one or more of the sensory impulses are absent, that is deafness or blindness. Medically handicapped, example hemophilia, leukemia. These come under medically compromised, and multi-handicap, that could be a combination of any of these above conditions. Novak's classification is physically handicapped, mentally subnormal, congenital defects, metabolic and systemic disorders, convulsive disorders, childhood autism, blindness or deafness, and neoplasias. Now let's start with heart diseases. Now congenital heart diseases are saying 8 to 10 cases per 1000 children, and risk factors include maternal rubella, diabetes, alcoholism, irradiation and drugs such as thalidomide, phenytoin and warfarin. Cyanotic defects are clinically evident when 50 grams per liter of desaturated hemoglobin is present in the arterial blood. So in infant, generally mild cyanosis goes unnoticed and the child appears normal and pink, and the cyanosis is only visible when the child cries or there is exertion in any form. Congenital defects include ventricular septal defect. This is the most common septal defect. This can come as an MCQ question. The other defects include atrial septal defects, patent ductus arteriosus, coarctation of aorta, aortic or pulmonary stenosis, and tetralogy of Fallot. Now, the various clinical and oral manifestations of congenital heart disease include clinically exercise intolerance, fatigability, respiratory infections, retarded physical growth, delayed puberty and low tolerance to stress. So these children basically are unable to play for a very long duration, get tired very easily, and hence could be an alarming factor if any of these conditions are noticed. Oral symptoms include cyanotic gingivitis, stomatitis gingivitis, delayed eruption of teeth, increased caries activity, structural defects of enamel, increased intrinsic dyschromia of dentition, which could be due to medication or other blood byproducts, and hypocalcification of secondary dentition. Rheumatic heart disease. It is an infection of group A beta hemolytic streptococci and has got a hereditary predisposition. The clinical features include major and minor factors. The major factors are carditis, polyarthritis, sydenhemcoria, erythema marginatum, and subcutaneous nodules, while minor are the previous history of previous rheumatic fever, polyarthralgia, and fever. So any of these two major and minor symptoms go to a diagnosis of rheumatic heart disease. Diagnosis is generally by throat cultures and increased ASO titers. Now, why is this significant in a dental operatory? They have an increased risk of infective endocarditis, that is, any infection in the body or the oral cavity will lead to this infection might travel to the heart and thus lead to infective endocarditis, and hence these patients should be treated under prophylactic antibiotic regimen. Preoperative septic mouthwash, that is 0.2% chlorhexidine glucolent, can be given to these children, and aggressive pulpal treatment and pulpotomy are generally contraindicated because of bacteremias. Now, how would bacteremia spread in a case of pulpectomy or pulpotomy? It might happen that unintentionally the files might go periapically and hence the infection travels in the blood circulation, and hence these pulpectomy or pulpotomy procedures are contraindicated for these patients. They can be treated under general anesthesia and all work should be completed in one session, and there is no contraindication for vasoconstrictors, that is LA with adrenaline. Sedation reduces apprehension or anxiety in young children. Analgesics, narcotics, barbiturates, sedative agents potentiate and prolong the effect of antihypertensive agent and thus leading to hypotension and syncope. These drugs should be used with caution in such patients who have got a history of rheumatic fever. Patient receiving monoamine oxidase inhibitors should not be given local anesthesia containing epinephrine because they might prolong its effect also. Now the next is infective endocarditis. What is infective endocarditis? An infection that affects the endocardium in valvular, mural and septal defects as well as in arteriovenous and arterioarterial short circuits. The initiating factor is endothelial damage. Now what happens is heart has got three layers. So outer, the middle and the inner endocardium. The blood generally flows with a smooth circulation in these vessels and throughout the body. But in case if there is a damage to these vessels, it causes turbulence and hence the cycle of infective endocarditis might start. So the initiating factor is endothelial damage. Now suppose if you've got a damaged heart wall, the jet stream effect of blood passing from these defects leads to sterile vegetation. So initially there is no bacteremia, there is no bacterial accumulation. Because of the turbulence there is only platelet, fibrin clot and thrombus formation. Now there could be an introduction of bacteria in bloodstream. This could be because of the dental infections or any infection in the body which leads to bacteremia, and these bacteria might also travel to this location of turbulence. Lesion traps bacteria. It acts as an incubator for these bacteria. The bacteria multiply and local myocardial abscess can form which might lead to congestive cardiac failure. And once this gets dislodged from this location, it can lead to formation of emboli, and this emboli can get deposited in any part of the vessels. Now this is a chart which shows bacteremia associated with dental procedures. Now here we can see that most of these procedures, extraction, periodontal surgery, scaling, endodontics, surgery, endodontics, even toothbrushing, dental flossing, interproximal cleaning with toothpicks, irrigation devices, chewing, all these procedures can lead to bacteremias, but they've got a different percentage in which bacteremia can occur because of these procedures. So one has to be very cautious when dealing with such patients and any of these treatment which can lead to bacteremia and hence infective endocarditis. So what solution do we have for these patients? So what are the oral procedures that require prophylaxis, requiring antibiotic prophylaxis? Extractions, periodontal procedures, implant placement, tooth reimplantation, placement of orthodontic bands, endodontic instrumentation beyond the root apex, periapical surgery, intraligamentary injection, and prophylactic cleaning and procedures in which significant bleeding is anticipated. The procedures which do not require prophylaxis are operative and prosthodontic procedures with or without retraction cord, local anesthesia injection, intracanal endodontic procedures, placement of removable appliances, impression making, exfoliation of a primary tooth, oral radiography, fluoride application, rubber dam application, and post-operative suture removal. So basically any invasive procedure will require antibiotic prophylaxis, and a procedure in which we know there is not going to be any invasion into the blood vessels or the gingiva which might lead to bleeding, the prophylaxis is not required. These are few of the systemic conditions which require antibiotic prophylaxis, which could be any of the congenital disorders. Patients not at risk from infective endocarditis are after coronary bypass surgery and 6 months after the surgery when the patient is asymptomatic. And special risk patients are those who have got a previous history of infective endocarditis, who require general anesthetic and have got a prosthetic valve. So what is the regime of antibiotic prophylaxis? We get a SAQ on antibiotic prophylaxis for infective endocarditis or heart diseases. So the standard general prophylaxis in adults is amoxicillin, which is 2 gram, and for children it is amoxicillin 50 mg per kg. Both these drugs are given orally 1 hour before the procedure in adults and in children. The person who is unable to take oral medications, so we shift from amoxicillin to ampicillin, and the dosage remains same, that is 2 gram in adults and 50 mg per kg in children, but the route is IV or IM. It is given within 30 minutes before the procedure. The initial one was 1 hour before the procedure, and this is 30 minutes before the procedure. Now if a person or a child is allergic to penicillin, then there are other regime, that is adults clindamycin can be given 600 mg, and in children clindamycin 20 mg per kg 1 hour before the procedure can be given, or azithromycin or clarithromycin can be given in adults 500 mg. The same drugs in children 50 mg per kg orally 1 hour before the procedure. And those allergic to penicillin before procedure and those who are unable to take oral medications, for them it is clindamycin 600 mg IV or IM, and for children it is 20 mg per kg IV or IM 30 minutes before the procedure. So this is the antibiotic prophylaxis that is required for children with congenital heart diseases. Now let's see the respiratory disorders in children, that is asthma. Now what is asthma? It is a hyperresponsiveness of airways and bronchial inflammation. The dental implication is major risk of acute attack in dental surgery. So suppose if we have not taken a case history and we suddenly when you are doing a dental procedure, the child might suffocate. So if we are not aware that the child is asthmatic, it becomes difficult to handle the situation. Medications contain sugars, so these children are more at risk for developing dental caries. And effect of steroid medication, that is extrinsic staining, immunocompromised, effect on oral pH and increased dental erosion, decreased salivary flow, and mouth breathers generally have gingivitis and enlargement. So because they are unable to breathe properly, many of these children are mouth breathers and hence they will have gingivitis and enlargement of the gums in the anterior region. Now what are the triggering factors for asthma? It could be inflammatory factors such as respiratory infections, work, allergens, irritants such as temperature changes, strong odors, cold air, stress, emotions, exercise, and the other factors that include tobacco, gastric reflux, pollutants, food additives and medications. Now, suppose if we've got a child in the dental unit, what could be the aggravating factors for asthmatic attack? It could be any substance which has got a very pungent odor, for example spirit. So that zinc oxide eugenol, which can instigate or trigger the asthmatic attack. The second could be anxiety. A child could be anxious because of the dental treatment, and hence it might lead to an asthmatic attack. The various signs and symptoms. Patients generally quickly recognize the symptoms, evaluate their mental status, and in most of these conditions, the patient will be unable to speak. The respiratory rate is more than 30. There is expiratory wheezing. On auscultation, we can feel a silent chest. Pulse rate is elevated, and on evaluation of BP, we can see pulses paradoxes. Now, what is the management? It begins prior to an emergency. So, beforehand, if we know that the patient is asthmatic, we can take all necessary precautions and be prepared if an emergency arises. Dentists should be well versed with the technique of taking metered dose, reduce any predisposing factors from the environment such as stress, airway and airway irritants. Once the patient has got an asthmatic attack, evaluate the severity of the patient's asthma. Suspend any dental procedures. Remove any objects present in the mouth that can obstruct airway or can be aspirated. In severe asthmatic attack, free access to metered dose inhaler. That is, if the patient is unable to take the MDI himself, the dentist should be aware that how it has to be given and how many puffs have to be given, and accordingly the dentist himself, the pediatric dentist himself, can give the metered dose inhaler to the child. In severe asthmatic attack, parenteral beta adrenergic agonist can be given, medical assistance, oxygen 3 to 6 milliliter per minute, and steroids can be given. Regular prophylaxis for these children is essential because they develop extensive stains because of steroids. Narcotics should be avoided. There is no contraindication to use of sedation, and rinse mouth with water after using steroid inhalers. So to summarize, the preventive measures should be taken, that is thorough medical history, prophylaxis for dental stains, precautions while using dental products with a strong smell. Dentists should be well versed with the use of MDI, and in case of an asthmatic attack in dental operatory, the dentist should be well aware that what precautions and how it has to be managed. The next is diabetes mellitus. It is associated with inadequate insulin needs to meet body demands. Classification, it can be classified as type 1 and type 2. Type 1 is insulin dependent diabetes mellitus. Type 2 is non-insulin dependent diabetes mellitus, which has got a maturity onset. Autoimmune is destruction of insulin producing beta cells. So the most common in children is type 1 diabetes. The goal of treatment is to maintain that glucose level and reduce potential complications of hyperglycemia and ketoacidosis. Diagnosis is fasting blood sugar level which is above 120 mg per deciliter, abnormal glucose tolerance tests, and elevated glycosylated hemoglobin test values. The oral manifestations include reduced salivary flow, burning mouth, candidiasis, altered taste, periodontal diseases, which is the most consistent finding, alveolar bone resorption, inflammatory gingival changes which mimic jugular venous pressure, enamel hypocalcification and hypoplasia, along with reduced salivary flow and hence increased in dental caries, increased glucose content in GCF. The dental management is aimed at implementation of preventive protocol. Morning appointment should be given because it has got more controlled blood glucose levels, and controlled diabetics receive the same dental treatment like a regular patient. Normal meals before dental procedures are advised, and fasting before general anesthesia, that is nil per oral, is modified for these diabetic patients because they cannot be kept nil per oral for longer duration of time. Direct pulp capping and pulpotomies are questionable in uncontrolled diabetics. Vital pulp therapy is preferred to extraction because there is delayed wound healing in such children. All children treated under anesthesia are admitted to the hospital, and prophylactic antibiotics for any invasive dental procedures should be given. This is the dental management of a diabetic dental patient. So on the left hand we can see potential complications and what are the preventive measures. So for hypoglycemia, thorough medical history and consultation with physician to assess glycemic control, disease severity and medications with hypoglycemic potential, monitoring blood glucose levels and dietary intake before treatment, avoidance of peak activity periods of insulin or oral anti-diabetic medications, and recognitions of signs and symptoms of low blood glucose level and timely administration of carbohydrate source. Infection and delayed wound healing, frequent dental visits to assess plaque control and to identify risk factors for periodontal disease, caries and candidiasis, post-operative antibiotic therapy if required, and avoidance of smoking in adults. Salivary gland dysfunction and oral burning, maintenance of adequate oral hydration, that is water, ice sheets, salivary substitutes, and restriction of caffeine and alcohol intake. Now the points to remember for a diabetic patient is early morning appointments, take meals plus diabetic medications before the treatment. For general anesthesia, nil per oral is adjusted accordingly so that the patient does not remain empty stomach for longer duration of time. Preventive protocol should be followed. Pulpectomies are preferred to extraction and delayed wound healing could be a complication. Now the next is blood disorders, in which we will be dealing with leukemia, sickle cell anemia and hemophilia. Leukemia. It is the second leading cause of deaths in children. It is an hemopoietic disorder in which there is proliferation of abnormal leukocytes in the bone marrow and dissemination of these cells into the peripheral blood. The abnormal leukocytes accumulate in the bone marrow and other tissues of the body. It can be classified as acute and chronic. Acute is most common in children, and second classification is based on the degree of differentiation or maturation of cells. So acute lymphoid leukemia, which is more common in children. The peak incidence is 2 to 5 years of age and cause is unknown. Ionizing radiations, chemical agents, genetic factors and immunologic disorders. The clinical manifestations include anemia, thrombocytopenia, granulocytopenia. Now the main reason for the decrease in other cells is because the bone marrow is producing more of WBCs and hence the production of rest of the cell eventually decreases, thus leading to decrease in RBCs and hence anemia, thrombocytopenia or granulocytopenia. The WBCs also that are produced are more of immature type and thus do not solve the purpose or the function of WBCs. There is increased irritability, lethargy, persistent fever, easy bruising and hepatosplenomegaly. Oral manifestations are seen in 29% of the children with leukemia, and these include regional lymphadenopathy, mucous membrane petechiae or ecchymosis, gingival bleeding and hypertrophy, ulcerations, chin and lip paresthesias, jaw pain, loose teeth and generalized osteoporosis, which is common in children. Now if we see what is the reason for chin and lip paresthesias, because the bone marrow is working extra hard, there is more production of the cells, and also once these cells are flowing in the vessels, they exert pressure on the surrounding structures. So if there is any pressure on the surrounding nerves, it might lead to chin or lip paresthesia. The jaw pain is also for the similar reason. Because of the excessive functioning of the bone marrow, there is thinning of the cortical plates and widening of the marrow space, loose teeth and generalized osteoporosis. Manifestations of jaws include loss of trabeculation, destruction of crypts, loss of lamina dura and widening of periodontal ligament space. There is strangulation of pulp and stasis of blood in vessels. Now the reason for strangulation of pulp is because as we all know that the tooth has got only one source of blood circulation, that is the apical region. From the same region there is entry and exit and hence the circulation of the blood. So once there is increase in the volume of the blood in a particular region, it exerts pressure and hence the pulp gets strangulated in that particular region because of excessive WBCs that are flowing in the blood vessels. Now the medical management is to induce and maintain complete remission, resolution of the physical findings and normal cell counts. Now these are the various phases that we can see in which the chemotherapeutic treatment of leukemia patients are carried out. That is induction, consolidation, interim maintenance, delayed intensification and maintenance phase. The dental management is consultation with the child's hematologist and oncologist, which includes primary medical diagnosis, clinical course and prognosis, present and future treatment modalities, present general state and hematologic state. So before we take this patient for a dental treatment, we ought to know that what is the status of the child in respect to the leukemia, what is the prognosis of leukemia, whether the child can take the drugs, whether the treatment can be electively carried out if required. Discuss the proposed dental procedure with doctors. There is no dental treatment done in relapse or the first remission stage, and the source of systemic infection should be removed. Routine treatment for the child should be done in complete remission stage. Complete blood count should be done on the same day before the treatment, and pulp therapies or root canal treatments are contraindicated. Now if the platelet level of 1 lakh millimeter per cube is adequate for all dental procedures, when the platelet count is less than 20,000, no dental treatment should be carried out. Good preventive program includes soft bristle brush. For erosive ulceration, the treatment is 1 part cowpactate plus 1 part Benadryl elixir, Orabase with benzocaine. For candidiasis, antifungal drugs such as nystatin, oral suspension and fluconazole can be given in resistant cases. So basically the treatment remains symptomatic for these children, that is for ulcerations, for fungal infections, and a preventive protocol to prevent any further oral diseases. The next is abnormalities of platelets. The abnormality of platelets could be in number or in function. Number is either increase in the number of platelets or decrease in the number of platelets, and in function is abnormal functioning of the platelets. So decrease in number is known as thrombocytopenia, increase in number is known as thrombocythemia, and in difficulty in functioning, proper functioning of these platelets is known as thrombocytopenia. Now thrombocytopenia is counts less than 1 lakh. It could be due to various reasons such as increased platelet destruction, increased consumption of these platelets, or decreased platelet production. The other factors include sequestration, that is excessive destruction of these, or dilutional, that is massive transfusions. So excessive destruction occurs in idiopathic thrombocytopenia. Mechanical injury, increased consumption occurs in DIC or thrombotic thrombocytopenia. Decreased platelet production is in bone marrow aplasia, acute leukemia, and vitamin B12 or folate deficiency. Sequestration, that is destruction of these platelets, which could be due to splenomegaly and dilution. When massive transfusions are given, it could lead to a projected decrease in the number of platelet counts because the volume has increased. Idiopathic thrombocytopenia. There are two types, that is primary and secondary. Primary is further divided into acute and chronic. Acute is seen in children, which is self-limiting. Chronic is more common. Secondary idiopathic thrombocytopenia could be due to the various underlying causes such as SLE, AIDS, after viral infection and complication of drug therapy. Lab investigations will show normal, low platelet count, normal or increased megakaryocytes in bone marrow, that is more of immature platelet cells, and accelerated thrombopoiesis, that is megathrombocytes. Bleeding time is prolonged and PT and APTT is normal. So basically, because there is deficiency in the platelets, we will see a prolonged bleeding time, but PT and APTT, which are the clotting factor detection tests, these tests will be normal because the clotting factors are normal. Dental aspects include submucous purpura, that is black currant jelly, blood blisters. Regional local anesthesia block can be given when platelet levels are more than 30 into 10 to the power 9 per liter. For dentoalveolar surgeries, these counts should be more than 15 to 10 to the power 9 per liter. And for major surgery, the platelet level should be more than 75 into 10 to the power 9 per liter. Aspirin should be avoided. Platelet transfusion, 1 unit raises the value by 10 into 10 to the power 9 per liter. Platelet transfusion, platelet sequestration is also rapid. That is, even if they are transfused, the destruction of these platelet cells is also very rapid, and hence half should be given just before the surgery and half at the end of the operation. Platelet preparations include platelet-rich plasma and platelet-rich concentrate. Risk of transmission because of these transfusions could be blood-borne infections. Dental management includes risk of platelet transfusion is reduced, and we can use local hemostatic measures such as desmopressin, tranexamic acid, topical administration of platelet concentrates, oxidized regenerated cellulose, and microcrystalline collagen. These can be put into the extraction socket to control bleeding. Conscious sedation and general anesthesia can be done in these patients, but with utmost care. The next is clotting disorders. In this, we will be dealing with hemophilia A. Now let's see briefly what is the clotting pathway. So here we can see it is the intrinsic pathway and this is the extrinsic pathway. Here factor 12 is converted to activated factor 12A, which further acts on factor 11, activating it acts on factor 9, factor 8, and then it acts on factor 10 and thus entering the common pathway. Similarly, in extrinsic pathway, factor 7 which is activated and it acts on factor 5 and thus entering the common pathway. So here we can see that factor 8, which is the main causative factor for hemophilia A, is in the intrinsic pathway, and the test which measures intrinsic pathway is PTT. So when we do the blood work for these patients, we will see an abnormal PTT, but PT will remain normal because all the factors of extrinsic pathway and common pathway are normal. So hemophilia is also known as royal disease. It is a group of inherited blood disorders in which there is a lifelong defect in clotting. There is deficiency of factor 8C portion of factor 8. So because the platelets are doing their normal job, the clot remains the clot does form in the initial stages, but over a period of time, because a permanent clot has not formed because of the deficiency of these clotting factors, the clot degenerates and again it starts bleeding. So hemorrhage and hemophilia, it stops immediately after injury, but after 1 or more hours, oozing starts. So suppose if we've done the extraction of the patient and we were not aware of the history of the child, the bleeding might stop immediately, but over a period of time, the patient might return back complaining of oozing from the socket. It is an X-linked recessive trait. So here if we can see that mother and father both are normal, so children will be normal. But in case if the mother is a carrier, there is 50-50% chance that the daughter and the son could be the carriers for the same. On the other hand, if the father is a carrier, both the girls will be the carriers in this stage. It can be classified based on the degree of severity, that is normal range, mild, moderate and severe hemophilia. The normal range is 50 to 150% of clotting factor, in which normal blood coagulation can be seen. While mild hemophilia is 5 to 50% clotting factor, moderate hemophilia 2 to 5%, and in severe hemophilia there is less than 1% of the clotting factor. So in mild hemophilia, bleeding problems usually are associated with extraction, surgery, severe accident, and these are often not diagnosed until later in life. While in moderate hemophilia, bleeding is usually associated with injury, knock or deep cut and can present like severe hemophilia. In severe hemophilia, bleeding is frequent and often spontaneous into joint, muscles and any sites including brain, and these are usually diagnosed in first year of life. The most common cause of bleeding is trauma, emotional stress, that is arguments, examination. Stress associated with dental treatment could also be a factor for bleeding. Clinical features include bleeding, that is hemarthrosis in the joints, bleeding in the joints. These are apparent before any physical findings. Severe arthropathy, that is limited range of motion and severe pain in these joints. In neck and airway, there could be airway obstruction. In soft tissues, neurologic compromise, spontaneous intracranial bleeding and hematuria. So basically any part of the body where bleeding occurs, because of the large amount of bleeding that is occurring, it might lead to the obstruction or pressure on the surrounding areas and thus compromising the situation. Most common joints involved in hemarthrosis are knee joint, ankle joint and elbow joint. The lab diagnosis, as we've discussed, there would be prolonged APTT, while rest of the tests will be normal, that is bleeding time and prothrombin time will be normal, and there would be low factor rate. Now what is the management? General management is obviously factor replacement. There is porcine factor VIII, recombinant factor VIII, cryoprecipitates, lyophilized factor concentrates. Life-threatening bleeding, we require 100% replacement, and half-life of factor VIII is 10 to 12 hours. Less threatening bleeding, we require 50% replacement. Mild hemophilia, when trauma is anticipated, transfusion as in factor VIII. Cryoprecipitates, DDAVP, that is 1-diamino D-arginine vasopressin. It is given just before surgery and repeated 1 hourly for 4 days. Intranasal spray and IV infusion can also be given. Antifibrinolytics, that is tranexamic acid, it blocks the lysine binding sites on plasminogen molecules. And epsilon aminocaproic acid. So these agents can be used in mild hemophilia. Dental aspects, episodic prolonged bleeding from nose, mouth or lips can occur. Hemarthrosis, that is ankylosis and erosion of joint surface, and it would be painful, but TMJ hemarthrosis is very rare. Hemophilic pseudotumors, that is local collection of the blood in areas where bleeding has occurred. Now let's see the different dental protocol that can be followed for these patients. Treatment location, the patient can be treated in a dental operatory, but we need to have a backup plan in case an emergency arises. The factor 8 should be given properly before the treatment starts where required. The prevention includes toothbrushing, flossing, rubber cup prophylaxis, supragingival scaling, and subgingival scaling is only undertaken after 10 to 14 days when the gingivitis subsides. Comprehensive dental assessment should be done at the age of 12 to 13 years. So this is basically done so that we know that what treatment the child might require in the future. Probably if the myofunctional therapy is given at this age, we might avoid extractions at a later stage for orthodontic treatment. The next is pain control, analgesia. We can give nitrous oxide sedation. NSAIDs are strict no, because in this also aspirin might increase the bleeding. Acetaminophen can be given. In severe pain, narcotic analgesics can be given. The next is restorative treatment. It is performed without factor replacement. PDL injection, local infiltration can be given. For small lesion, nitrous oxide sedation. Rubber dam, retract and protect the cheeks, lips and tongues. Retainers with subgingival extension are not advised. High-speed vacuum and saliva ejectors should be removed carefully because it might lead to sublingual hematoma. For example, now when you are treating a patient, we generally keep cotton rolls to isolate the tooth structure, and then you have your suction tips placed on the cotton rolls. Now you would have noticed that when you remove the suction tip and then you try to remove the cotton is sticking to the mucous membrane. So in these patients, even while pulling that the cotton roll, the mucous membrane that is pulled might lead to severe bleeding, and hence we do not want the bleeding to exaggerate in these situations. And thus what can be done is you can wet the cotton rolls and then slowly remove them. Care should be taken while placing the X-rays because the sharp edges of the IOPs might also might cause the bleeding. Periodontal surgery. So after supragingival scaling, for 7 to 14 days, subgingival scaling or the replacement therapy can be done. PDL and frenum surgery, both factor replacement and antifibrinolytic agents can be used. No factor replacement is required for probing. Pulpal therapy, pulpotomy and pulpectomy that can be done. Extractions might cause bleeding. Vital pulpotomy and pulpectomy can be done under local infiltration. And for exposed pulp, intrapulpal injections can be given to control pain. Orthodontic treatment. Bands should be placed carefully or avoided to avoid lacerations. Avoid leaving any sharp edges which might cause trauma or ulcerations. Preformed bands can be used. Longer acting wires can be given to these patients so that the frequent appointments are not required for the adjustment and hence trauma to the child. Oral hygiene measurement technique and measurements should be told to the patient. In oral surgery, after extraction, direct pressure with gauze, topical application of hemostatic agents can be used. Socket packed with an absorbable gelatin, that is sponge or gel foam, microfibrillar collagen or topical thrombin or fibrin glue can be sprinkled over the wound. Resorbent sutures are recommended. Simple extraction, single rooted primary teeth, complete root development, factor replacement is required, while partial root formation, antifibrinolytic agents and local hemostatic agents can do the job. Normal exfoliation, no factor replacement is required. Bleeding can be controlled by direct finger or gauze pressure. Thus, to summarize, if you have a LAQ on hemophilia A, we have to write the etiology, classification according to the presence of factor 8, that is normal, mild, moderate and severe, the clinical features, lab diagnosis, medical management, that is factor replacement, and the dental management under various headings. The next is sickle cell anemia. It is a autosomal recessive hemolytic disorder. It forms a linear polymer upon deoxygenation which results in sickling of erythrocytes. It is less soluble than normal and results in gelatination of erythrocytes, that is sickling. Both parents should be carriers or should have the disease. Results from an abnormality of the beta chain hemoglobin. So there is production of hemoglobin S rather than hemoglobin A, which is present in normal individuals. Sickling procedure, how does it occur? There is rapid destruction of sickled erythrocytes and hence anemia. Stagnation of erythrocytes with resultant interference in the vascular circulation. There is collection of the affected erythrocytes in the vital organs of the body with resultant organomegaly. So wherever there is destruction or there is accumulation of these sickled cells, it will lead to the improper circulation of the blood supply in a particular area and hence cause various complications. The clinical manifestations of sickle cell anemia are recurrent infection, which results in aplastic crisis, progressive deterioration of cardiac, pulmonary and renal function, sickle cell crisis, vaso-occlusive crisis or sickle cell hepatomegaly. Skeletal changes include osteoporosis and softening. Erythroblastic hyperplasia in the long bones causes medullary hyperplasia, widening of the diaphyseal trabeculae and thinning of the cortical plates. The radiographic changes include generalized radiolucency, loss of trabeculae with prominent lamina dura, bone growth may be decreased in mandible, retrusion and teeth may be hypomineralized. Infarcts in the jaw could be mistaken for toothache, that is, local accumulation of the sickle cells might cause pain and one might confuse it with the tooth pain. There is a stepladder pattern, that is prominent lamina dura and horizontal trabecular pattern of PTM. Radiolucency in the apices of the teeth and mandible. Hypomineralization of the dentine can be seen. The dental management includes, except under emergency situation, treatment of patients with sickle cell anemia should be avoided. Dental appointments should be short and long stressful procedure could be avoided because stress might also lead to sickling. Preventive programs should be advocated to maintain excellent oral health. Sickle cell anemia have defective spleen function and hence they are vulnerable to infections and hence prophylaxis is required. Restoration of teeth, pulpotomies are preferred to extraction and periodontal therapy can be done. The surgical protocol for sickle cell anemia is most patients will be taking low doses of antibiotics. Additional to the antibiotic for procedure is debatable. That is, as we've already said, these children are more susceptible to infections, so they would be taking low doses of antibiotics. So there is no need for giving additional antibiotic for a dental procedure. Local anesthesia with vasoconstrictors is not contraindicated. Use of nitrous oxide is also not contraindicated. General anesthesia management includes adequate oxygenation and ventilation are established, circulating volume and cardiac output should be satisfactory and acidosis is avoided before and after anesthesia. Hypoventilation under anesthesia may result in hypoxia and acidosis and hence intravascular sickling. Thus, to summarize, if you have a question on sickle cell anemia, we need to write etiology. Sickling, what can sickling lead to? That is difficulty in circulation, accumulation of these sickle cell in a particular region, clinical manifestations, radiographic features and dental management. So these are the long questions that are generally asked. Explain the medical management of children with congenital cardiac anomalies, management of an asthmatic patient in dental operatory, explain in detail etiology, oral manifestations and dental management of hemophilia or hemophilia A, describe etiology, classification, oral manifestation and dental management of a child suffering from leukemia. Short answers include antibiotic prophylaxis and oral manifestation of hemophilia. Thank you for your patient hearing. Hope to see you all soon.